So we are live in 5, 4, 3, 2, 1. We are live now.
Thank you so much, friends, for joining us in this fifth webinar of Indian Orthopedic Association, which is on a very important subject, totally arthroplasty in a valgus knee. And as we all know that valgus knees are having the different principles of the treatment and a little more difficult to treat because one, they are not so commonly seen in our part of the world, and second, they need a special care and sometimes the special implants as well. Dr. Anil Arora is the convener for today's webinar, and the well-known faculty who will be introduced by Dr. Anil Arora. Dr. Anil, over to you, please.
Yeah. Good evening, everyone. Thank you, Dr. Rajeev. Thank you, IEA, and thank you, IOA, for this for asking me to convene this webinar. I'll quickly rush through my slides because we have 3 faculty who are waiting to board the flight. So, put on slideshow. Yeah, visible, Dr. Rajeev. It's visible.
Yes.
Welcome
yes.
you all. Welcome you all, and thanks, IU officials, to participate in this webinar. I think they are also, Dr. Chadda is also traveling. I'm just going to introduce our faculty quickly in alphabetical order. Dr. Ajith, our current president of Indian Arthroplasty Association. Blessed to have him with us today. He's from Mangalore. Myself, I am from Delhi. And Padam Shri Dr. Ashok Rajgopal, who can join us any minute. I had a word with him. He's group chairman. He's from Medanta Medicine, Delhi, NCR. There's a lot of awards, more than 35,000 knee arthroplasty. Dr. Padi is with us, who's going to organize next IAA conference at Bhubaneswar. I'll just rush through Krishna Kiran, a dynamic young genius arthroplasty surgeon from Hyderabad. Dr. Manuj, Virat Kohli, and Sachin Tendulkar combined of Indian Arthroplasty Association. A lot of awards with him, a lot of centuries, a lot of thousands of joints he had done. Dr. Mrinal Sharma, author of 2 books. He has written 2 books on knee arthroplasty, hip arthroplasty. He's from Faridabad. Dr. Chandrashekhar, an arthroplasty surgeon from Bengaluru. Dr. Kalia from Rishikesh. He's heading on an Institute of Medical Sciences, Rishikesh. And Dr. Rajeev, who is holding Indian Arthroplasty Chair of Indian Orthopedic Association. He has been past president of IAA, quite active. And he bears the flag of academics of IAA in various organizations. Dr. Rajkumar, our current secretary of IAA from Coimbatore. I hope he has joined. Dr. Unmesh Mahajan from Nagpur. He runs his own center. And Dr. Vikas Kapoor from Kolkata. So we are very thankful for the faculty for sparing time. I'll be just giving a quick introduction of valgus knee, how it is different from varus knee. Shall I get going, Dr. Rajeev?
Yes, please go.
Okay, thank you very much. So friends, lateral knees in totally arthroplasty for valgus knee is a bit complex because there are a lot of structures on the lateral side which are taut in different positions of the knee. And this release is sometimes unpredictable in long run as far as longevity of implant is concerned. So iliotibial band and posterolateral capsule are responsible for contracture of the knee in extension, while lateral collateral ligament and popliteus in flexion as well as extension. And popliteofibular ligament is taut, it keeps the knee taut in flexion. There can be contracture of muscles in severe cases of biceps femoris and lateral head of gastrocnemius. There could be tight lateral retinaculum, putting the patella laterally subluxed or even dislocated. The structure on the medial side are lax, including medial collateral ligament. And not only soft tissue, but there are bony abnormalities, which is different from varus knees. The lateral femoral condyle could be hypoplastic. And if you use posterior condylar axis for femoral rotation, you will throw your femoral component in internal rotation. So one has to be very careful. Besides this, there could be valgus external rotation, remodeling of the distal femur and proximal tibia. There will be unusual neck shaft angle, and there could be tibial bone defect, which is largely contained in these cases, unlike varus knees. There can be diaphyseal bowing, valgus tibia valga. There could be stress reaction in the lateral part, lower part of the fibula, or they can have a frank stress fracture. Many of these patients, especially rheumatoids, they have hindfoot and forefoot deformities. And the valgus knee could be in hyperextension or like in RA inflection. Of all the classifications, majority of surgeons follow Ranawat's classification, which is quite simple, into 3 grades. Grade 1, less than 10-degree valgus deformity, most common deformity. It is correctable, and the MCL is intact, largely intact. Grade 2, deformity, tibiofemoral angle between 10 and 20 degrees. MCL is elongated but functional. It could be rigid. And grade 3 is more than 20 degrees of deformities and incompetent MCL. Then Mulaji and Shetty, they further modified this classification and included hyperextension and flexion deformities, as well as extra articular deformity into this classification. Now, while balancing the soft tissue in valgus knee, one has to balance between deformity correction, release, overzealous release, and long-term stability, which is going to affect longevity of total knee arthroplasty. As Dr. Rajeev pointed out, that they're quite complex. The extension release advised earlier in 80s led to very high rate of late onset iatrogenic instability, and Whiteside's cautioned against popliteus tendon, that one need not to release it inadvertently. It should be released only in case of extreme tightness, because it's a dynamic flexion stabilizer. Sliding osteotomy introduced in 2002, and then pie crusting technique in 2004, and the most commonly used, less extensive inside-out technique of Ranawat in 2005. Dr. Manuj Wadhwa will show us some videos on this. And then Mulaji introduced navigation for lateral femoral epicondylar osteotomy. Whiteside's releases advised long back usually are not followed nowadays. He advised releasing, if the flexion is tight, releasing lateral collateral ligament and popliteus. If extension is tight, releasing iliotibial band and posterior capsule. But if there is overall tightness in flexion as well as extension, then releasing all 4 structures. This usually leads to late onset instability. The most commonly used technique is that of Ranawat. Majority of surgeons follow it, in which you cut the distal femur and proximal tibia, you balance the extension gap by soft tissue release, and then you balance the flexion gap by adjusting femoral cuts. So in extension balancing, you remove peripheral osteophytes, extend the knee, and then palpate tight structures. You release PCL, and then you release posterolateral capsule at the level of tibia, preserve popliteus, do pie crusting of iliotibial band, and majority of time you are able to balance the knee in extension. For flexion gap balancing, the LCL is not released in these cases. And this is one, I'll just skip these diagrams. This is iliotibial band, pie crusting, and there's the popliteus, and there's the posterolateral capsule. Dr. Manuj will show them. For flexion balancing, you place the block parallel to the tibial cut, and you raise or lower it to achieve a symmetric flexion extension gap. And it's mainly by bony cuts rather than soft tissue releases. And if you're not following this method, one can, for femoral rotation, follow Whiteside line, perpendicular to the Whiteside line, or parallel to inter-epicondylar axis. And if the lateral tissue is tight, one can do pie crusting in the posterolateral corner. You can use CR knee or PS knee. Ranawat advocated using a PS knee, citing its own advantages. One can lateralize it, and PCL is usually tight. These are severe deformities. This was post-traumatic knee with a lax MCL. A VVC implant was used. One needs to have CCK or hinged implant if there is severe ligamentous instability or there is hyperlaxity. To summarize, there is not enough evidence which is the best technique for lateral soft tissue release, but majority of surgeons, they follow Ranawat's method. Pie crusting is better than complete release. At all costs, one should avoid complete release of popliteus. It gives rise to late instability. Be prepared with one level hair constraint. And complication rates in valgus knee as compared to varus knee are slightly higher. Thank you very much. I'll stop sharing my screen.
Thank you, Dr. Anil. That's a very good introduction to the subject, which we all agree that it's not a subject which is easy to follow. I'm sure that Dr. Manuj Wadhwa will show his further expertise of how to do a right kind of the soft tissue release. And I'll invite Dr. Manuj to speak on his topic of balancing the valgus knee and a soft tissue release. Manuj, over to you, please.
Yeah, thanks, Dr. Rajeev. Thanks, Anil, for giving me the platform today. And valgus knee is not the mirror image of the varus knee. Rajeev, can you play the video, please?
Yeah, sure.
Yeah, valgus knee has a bony deformity, with Dr. Anil has said, as well as soft tissue losses, mainly pertaining to the distal and posterior femoral condyle and the tibial plateau. Now, in this case, I'll not be talking about the epicondylar osteotomy, just pertaining to soft tissue release in different case situations. This is a typical Ranawat grade 3, as you see, a stretchable deformity. My workhorse is the midline incision. Once you've gone through, you in subluxed or dislocated patella cases, only close cases, I use a lateral approach. Otherwise, my workhorse is the medial parapatellar approach. But the difference is you only release up to the mid-cornal plane of the tibia. My first step always is to use a cruciate retaining knee for majority of the cases. I'll show you both platforms today. If you are using a non-navigated system, because for a release, you do not need a navigation across for understanding the parameters, you medialize the entry portal. You always have a defect onto the lateral side. As you see out here, the lateral femoral condyle will be hypoplastic as compared to the medial femoral condyle. You see 9 mm of the medial as well as 4 mm of the lateral condyle. Here the tibial rotation is extremely important. You take it up to the center of the ankle. You don't go into second ray because foot is normally plano-valgoid in these cases. As with Dr. Ranawat, it's a tightness and extension, and you do a pie crusting of posterior capsule as well as the iliotibial band. Now, setting up femoral rotation is the key. You never go along with the posterior condyles alone, because then you will make your femur cutting internal rotation. It is normally in the epicondylar axis or perpendicular white sides line. You see your stability across both in flexion and extension. If your knee is stable in flexion as well as extension, you're already through with it. Otherwise, you have to move back in, identify the tight bands on the lateral side and do a pie crusting. Now you see your stability getting on in full extension, mid flexion, as well as the full flexion. At all stages, your knee has to be stable in flexion and extension, and the patella has to fall into the sulcus, a good talar tracking, as you see in all these skyline views with just a CR knee. Talking a bit on a close-up view of the pie crusting, we release the posterior capsule and then try to identify the tight area spreading the laminar spreader. If you still have a laxity developing medially, you go back in and again identify the tight structures left in, use a number 11 bleed or a 18 gauge needle. Release the tight areas till your gaps become equal and squarish in both flexion and extension. This is a rigid valgus knee. As you see out here, a lot of deformities with flexion, contractures developed up. So these are the cases in which you have a contracture of the hamstrings also, as well as the lateral subluxing patella. As you see out here, it goes more than 40 to 50 degrees on the lateral side. The same way, the midline incision, medial parapatellar approach, only release up to the mid-cornal plane, reject the osteophytes, sublux the patella laterally, take out the loose bodies, a lot of hypertrophic osteophytes are there around the lateral ridge. You take them off. Once you're through with it, release the PCL. So medialize the entry portal with a step-guided leg. Once you have done your resection of your distal femur, you will always get a hypoplastic distal femoral condyle. Release the patellofemoral ligament laterally. Again, with Dr. Anil, parallel to the tibial cut, perpendicular to the right side line, and in axis with the trans epicondylar axis. Setting this femoral rotation right is extremely important because you don't want internal rotation of your femoral component and the patella falling laterally. So this again is hypoplastic lateral femoral condyle. As you see out here, you have a trapezoidal gap. You go back and release the ligaments, the patellofemoral ligament, and do a pie crusting of the tight posterolateral structures. Take off the budding osteophytes on the lateral side. Check your spacer blacks, both in flexion extension. It is still loose on the medial side. You move back in, do a pie crusting of the tight structures, which is very, very important to have an optimal release. Till your medial and lateral structures are there. Very rarely we move on to the CCK or higher amount of hinges as a constraint on epicondylar osteotomy, but they're always in a backup. Your knee is good in flexion extension, but the patella subluxes laterally. My favorite part is the outside in approach, saving the synovium, but also at the same time trying to save the lateral superior and inferior genicular vessels. Once your patella starts falling into the sulcus and your release is optimal. Now it's the third phase where you have external rotation of the tibia still persisting, for which we do IT band release. And once you've done an IT band release, you address to rectangular flexion extension gaps, an optimal soft tissue release, your patella falling into the sulcus, and external rotation of the tibia corrected. So with this, your patient walks comfortably. Only in those cases where there's still stretching of the MCL, you add up to the constraint in those cases, or do an upsliding medial condylar osteotomy. So the art is in getting the right kind of a balance for these kind of things. So Rajeev, any questions, I'll be more than happy to answer, because then I'll have to board my flight.
Yes, thank you, Manuj. I think it was a wonderful demonstration of the soft tissue release. To keep the ball rolling, Manuj, you said that you prefer the external release for the subluxating patella.
Yeah.
So, just for the viewers, can you explain that part? Because that is the part which is probably not so discussed in most meetings.
Yeah. Initially, for last couple of years or decade or plus, I was always doing the internal releases in those cases. But the tight structures are externally, not internally. So once you start addressing and understanding, this was a very good paper from Rajesh Maniyar on the 3 step 1, step 2, and step 3 release in those cases. Once you start realizing that the contracture of tissues lies into the outer structures, the synovial, beyond the synovial sheath, onto the vastus lateralis and those tight IT bands. So unless or until you release those tight structures, again, depending, it's not a circumferential release you have to do. You have to start from the tibial side and start moving up. So you have to identify where is the tight band, and those particular areas you have to release, maintaining the synovial soft tissue sleeve.
That's very right. Anil, will you take it over?
Yeah. So Manuj, if you have time, I'll ask you one more question.
Yeah.
See, because there is medial laxity and you're using a CR knee, you need a lot of lateral release. Any concern with raising the joint line with a CR knee?
CR knee rather is preferable for these cases because your MCL is already lax. You need to have a PCL to give you a strong abutment. So it is around. So the only point for a PS knee is you have an option of lateralizing the femoral component, thinking we'll have a patellofemoral tracking, but it doesn't happen. Once you start playing with the CR knees in a big way, you start lysing, you give an additional ligament because your MCL, we have to remember, is always stressed out. We might say we have released, but it's all stressed out. So you need one strong medial pillar to give you a stabilized knee. So CR knees, if you can do with those systems, is definitely better than a PS knee for these valgus deformities. Only in the cases, like the second case that I showed you was a very stiff knee. Despite sort of releasing the structures, I had to release the PCL in those cases. So it's not you are married around to saving the CR knee, but if I would arbitrate on a huge volume that I go through, 90% of the cases I am able to retain the PCL. 10% cases would do a PCL sacrificing me, whether a PS or a CCK.
So Manoj,
I agree with you, Manoj, that CR knee in many of these situations is a better joint. Another short comment, Manoj, that you had shown the balancing of the joint using the spacer.
Yeah.
And I think that is a very good way instead of just putting the implant and seeing it, because once you place the trial implants, you do give rise to some kind of a restraint, which is inbuilt in the implant. So I think the right approach of checking the balance is using the spacer. I think all of us will agree on that. Deva, you have a comment on this?
I think in severe fixed valgus knees, the PS CR is a better option. PS is a better option because already the MCL will be not so much redundant. So in a severe fixed valgus knee, severe valgus knee, maybe we can go ahead with a PS or CR, whatever Dr. Manoj is telling the points. But in a non is a correctable one, we can go ahead with any of the CR or PS. It's anything can be possible.
So,
Dr. Ajith, your comments on this?
Manoj,
Manoj,
any point in favor of doing a kinematic alignment in these knees?
Vikas, yeah.
Vikas, you're pulling my leg for a valgus knee. Kinematic is not the one. It's more for a varus knee, gross varus knee. But Deva, to point your stuff right, once you start retaining the PCL in a lot of cases, even with those FFD cases also, you can do very well balanced stuff with retaining the PCL. The only thing is you have to start playing. You cannot just do a CR knee in these cases. You have to do in all cases. And a lot of flexion contractures. Once you start doing all those armamentarium, you realize that actually releasing the PCL is not required, though you always have those options on table. It's, as I said initially, if you realize that, okay, without releasing the PCL, my knee is not getting balanced, do release the PCL. But if in a valgus knee where the MCL is always going to be stretched, you maintain a second pillar, and the second pillar is the PCL retention, you will always have a more stable knee for a long-term future.
Manoj, but just carrying on the discussion which Krishna had initiated, in a valgus knee, you will avoid a varus cut for sure for tibia.
Yeah.
Dr. Ajith, you had a comment on this.
Yeah, because
Dr. Ajith. Yeah.
Dr. Manoj, I have a question.
Yes.
Yeah, please.
See, one is in a fixed valgus knee. I'm Dr. Deepak Inamdar from Bangalore.
Yeah, Deepak.
Yeah. So one is a lateral approach for a fixed valgus knee.
Mm-hmm.
The second, common peroneal nerve palsy incidence in your cases for a fixed valgus, because in some papers, studies have seen more than 12 degrees is an indication for a fixed valgus that they may develop a post-op palsy. Recently, I had one. So I want an opinion on both of these.
So the question is a fixed valgus knee, and that too in high amount of flexion. Those are the cases in which we should be concerned about saving the common peroneal nerve. Also, one of the tricks in those cases is once you do a release, keep the knees in flexion with the pillows for a short amount of time and gradually stretch those knees. For me, an absolute indication for using a established lateral approach is once I have a dislocated patella or a patella which is totally fixed to the lateral gutter. Only in those cases, I would directly go with a lateral approach. Otherwise, in my hands, I would still use my workhorse, which is the medial parapatellar, and release the lateral side in those cases. But nevertheless, people have been using the lateral approach for a lot of other cases also. But I personally feel that only in the cases where you have a patella which is lying in the lateral gutter, which is totally adherent, where you do not have sufficient soft tissues on that side, are the cases where there's an absolute indication for a lateral approach.
Okay, thank you.
Thank you so much, Manoj. I think we'll just carry it on with Dr. Krishna Kiran showing us the epicondylar osteotomy, and that I'm sure that will be addressing to some extent how to avoid these nerve palsies in a fixed flexion and valgus deformities. Krishna, please.
Thank you, sir.
Thanks, Rajeev. Krishna, I will take a leave. I have to just board the flight. And best
Thank
wishes
you,
for a
Manuj,
wonderful
and have
webinar.
a safe flight from all of
Thanks,
us.
Manuj. Thank you very much.
Thanks. Thank you. Thank you, sir.
I've done my observations here.
Sir, is my
There
screen?
for 3 days. You were on the teams.
My screen is visible, sir?
Yeah,
Yes,
visible.
it is
Krishna,
visible.
visible.
Yes.
Very clear.
Right. So, I think although this is a little bit out of turn, I must apologize. I'm also traveling, and my flight is there in a while. I'll be talking about computer-assisted lateral partial condylar slide using a subvastus approach and a cruciate retaining knee, all of which are considered
Do you
to
have
be.
a zoom on here in this?
Sorry. So the idea is to talk about CAS-assisted lateral partial condylar slide for uncorrected valgus knee, focusing on the technique and tips. And we will also be doing these surgeries through subvastus approach and using cruciate retaining knees. So all these are actually no-nos when we are looking at conventional teaching for valgus knees. And I'll give you justification for each and every step why we do what we do. So we all know that the type 1 is the correctable valgus deformities, and type 2 are the non-correctable but intact MCL. And in type 3, you have an MCL which is incompetent, and of course, you can have varying degrees of extra-articular or a HTO which has been overcorrected into valgus, which can constitute the minority of cases in valgus knees. Now, the traditional teaching is to cut the bone perpendicular to the mechanical axis, which will result in a trapezoidal gap, which is tight laterally and lax medially in some of the situations. And this is traditionally addressed by releasing the ITB, the LCL and the PLC through pie crusting, sometimes the posterolateral capsule osteophytes, and also the popliteus. And this typically entails an increase in the flexion gap, necessitating a limited tibial cut, which is perpendicular to the mechanical axis. And this makes PCL secondarily tight and requires a PS or a higher constraint implant for balancing. Now, this is a conventional way of doing surgery. And this is a case example of a cruciate retaining knee in a very severe valgus deformity, which we have done. Now, the problems with a valgus knee, and if you notice some of the postoperative x-rays, are this sort of an imbalanced situation where the medial side is still lax and the lateral tightness has not been able to be balanced. And if you keep on releasing the lateral side, then the gap will increase so much that you will have no choice but to use a very thick insert with constraint. And using these thick inserts can secondarily lead to peroneal nerve palsy. And these sort of imbalances, which may look innocuous to begin with, do progress into more MCL stretching. And we all know that the valgus knees usually fail with instability, while varus knees fail with aseptic loosening. And this must be kept in mind while making a decision regarding the implant selection during surgery. And if you have any doubt, it is better to use a higher constraint implant rather than committing to either a CR or a PS or any particular type of design. And these usually require hinged reconstructions. It was probably a missed MCL incompetent situation which warranted a hinged reconstruction to begin with. Now, this is a case example of a 56-year-old lady with bilateral knee pain and deformity. And left side, you can see with a type 2 valgus, which is non-correctable, but the MCL appears to be competent because the valgus stress is not opening medially. And typically, this entails a situation where you take a limited tibial cut and a femoral cut perpendicular to the mechanical axis. And now you have a tight lateral side to contend with. And these are all the evidence for the use of this particular technique, the subvastus approach, the role of CAS, prerequisites for cruciate retaining implant, and what is the indication for lateral partial condylar slide. So why do we use subvastus approach and cruciate retention? Suppose you have to do a lateral retinacular release, the patellar vascularity is better preserved. There is potentially early recovery, and there is risk of inadequate exposure for lateral release and malalignment with the subvastus approach per se. But when you combine it with CAS and the use of a partial lateral condylar osteotomy, you avoid the need for any of these particular situations. The cruciate retention is possible when you are able to balance the knee and there is no residual medial laxity. But if you have medial laxity, then a varus valgus constraint, or in some situations, a hinged replacement may be a better option. The retention of LCL and popliteus are prerequisites to avoid late instability because of over-release. And this is a bone-conserving option, especially when we are looking to do a partial lateral condylar osteotomy. In the small Indian bones, where you cut a box and then you cut the condyle, then sometimes the condyle will fracture. But if you do a CR or a deep dish type of insert, then doing a lateral condylar osteotomy is an easier option and lesser risk of condylar fracture is there. Now, this case example which we showed, this is the navigation pictures. Of course, we do now have the robotics, and most of you would agree with me that the problem is more in extension than in flexion. And although lateral condylar hypoplasia in flexion has been described in the literature, we have also seen an occasional case where there is a hyperplasia of the lateral condyle into a central tibial defect. And this must be kept in mind. And we must not blindly go with increasing the external rotation or decreasing it, but tailor it as per the individual situation. Now you can see here, when we are making a plan, the limited tibial cut about 3 millimeters at perpendicular to the mechanical axis. And since we are doing a CR, we're taking a 7-degree posterior slope and an external rotation of 5 degrees for deemed appropriate for this patient. And after you do the trial reduction, the residual valgus, and I emphasize here that it is essential to have some sort of a technological measure intraoperatively before we commit to these sort of procedures, because otherwise everything will become a blind issue. So once we did an osteophyte removal, posterolateral capsule release, and ITB release from the Gerdy's tubercle, still there was residual 6 to 7 degrees of valgus deformity. And at this stage, we will commit to a lateral epicondylar osteotomy. And this is how you do it. You take a part of the condyle, not just the epicondyle, and this makes fixation easy. So 1/3 of the condyle or 1/4 of the condyle is cut with a saw, and it's a relatively simple procedure. And the moment you cut the thing, the deformity gets completely corrected, and you now distalize the fragment and posteriorize it to correct both the extension and flexion gaps and provisionally fix it in that position. And then once your trial reduction now shows a good position, the overhanging distal and posterior parts of the condyle are now trimmed using either a ronger or a bone cutting instrument. And this is fixed to the remaining bone with a large surface area for fixation. And this will give us, and you can see here the subvastus approach and the nice patellar tracking which is seen. Of course, there are situations where there is a patellar maltracking which is there pre-existent, pre-surgery. These will require some sort of an outside-in type of lateral release, which was elegantly demonstrated by Dr. Manuj. And this is the post-operative picture showing full correction of this deformity. And that's the X-ray showing the correction of the deformity with the 2 screws in place. And there is no change in the rehab protocol for these patients, where we allow them full weight bearing without the use of any brace. Another case example with a fixed valgus deformity, again computer-assisted use of a thin polyethylene insert about 9 or 11 millimeter in these complex cases, with the retention of bone for the future revision surgery. So the take-home message is that subvastus approach is an option in these cases because it facilitates faster rehab, patellar tracking, and preserves patellar vascularity. CAS gives us accuracy and quantification of the deformity, and the use of a lateral condylar osteotomy instead of doing an individualized soft tissue release of these multiple structures make the operation more predictable and allows us to use less constrained implants with reasonable long-term outcomes. Thank you.
Thanks, Krishna.
Thank you, Krishna. Dr. Anil, would you like to take it forward?
Yeah. So, Krishna, can we ask you a few questions before you board the flight?
Sure, sir. No problem.
So, because see, the lateral femoral condyle is quite often hypoplastic. Have you ever landed in fracture of that part which you have osteotomized of the sliding osteotomy? Any intraoperative fracture you encountered because they might be osteoporotic or thin?
The distal part of the condyle is hypoplastic, and sometimes the posterior part. But if you look at mediolaterally, the cortex is actually quite hibernated because the patient is load-bearing on these conditions. So, and since you are doing a cruciate retaining design with osteotomy, which involves about 1/4 to 1/3 of the condyle, we have not encountered any non-union or any sort of a fracture of this condyle in our practice.
Yeah,
But if
great.
you
One
did a
more thing
PS
also, Krishna, that this bone is quite thick, sclerosed, the lateral condyle.
correct.
So
That's
the
right.
fracture is relatively uncommon.
Uncommon. The only situation when it can fracture is if you cut a very big box in a female patient with a very small sized femur, and now you take another part of the condyle off, then you are in a trouble because sometimes the remaining condyle can just fracture. So that is one of the reasons why we developed the technique in conjunction with a cruciate retaining or a ultra congruent type of insert rather than a box and a cam post mechanism. That is the idea.
Dr. Ajith has a
Yes,
question.
Ajith, you have a question, please.
Krishna, very neat technique, very nicely shown. Generally, what we or when we would probably, or at least I would probably do a osteotomy is when I've done all the releases and found that in spite of all that, there is a residual deformity, that's when I do it. So you would say that doing this first sort of prevents or minimizes the extent of releases that you need?
Absolutely. So we don't do any release at all. So the only release I would do is the posterolateral capsule release and osteophytectomy, and then the ITB release from the iliotibial band. And that is the release which is done because majority of the deformity is in extension. And if you had a deformity which is extending from extension into flexion, then now the LCL and the PLC comes into play. So we don't release any of the LCL and PLC as a pie crusting or anything because it is unreliable, number one, even in experienced hands. And we notice that generally we are not able to balance the medial to the lateral side in these situations. And third is you have to up the level of constraint. So if you are committing to a partial condylar osteotomy as your go-to in a non-correctable valgus, you have to do it first. It is not a salvage operation when you have already released everything and then that becomes a disaster because now you have already cut the thing distally at the level of the joint line and now also removed it from the bone. So then you will definitely have to use a TC3 or a higher constrained implant. So if you commit at the state of ITB release and then you commit to the lateral condylar osteotomy or you do your pie crusting, whatever is comfortable. But if you did a pie crusting, I would be more comfortable putting a PS implant than in a CR implant in that situation.
Very right.
Wouldn't it be a straightforward take-home message, Krishna, that it's better to just go ahead and do a sliding condylar osteotomy and then just balance it out and leave it instead of trying any other tricks on that knee?
Absolutely. So I think this, in my hands, this is the go-to operation. It is much more predictable than doing all these sorts of releases and then trying to compensate the residual instability we have with more constraint and options. And you also, I think, are similar in thought process. You would do a CR reduced insert with an osteotomy.
Krishna, there is a question for you.
Yes, sir.
Krishna, Dr. Mahajan here.
Yes, please.
Yes, sir.
Is it
Can you speak loudly, please?
Unmesh, we can't hear you.
Basically, is it a best option for a fixed valgus deformity to have a osteotomy straight on rather than doing it at the last option?
Yes.
Can you hear me?
Absolutely. So unless you have an MCL incompetence, now that is a different ball game altogether. But if you had a type 2 valgus where it is fixed, but the MCL is competent, then the osteotomy is probably the go-to for me. But if you had an MCL deficient situation, then you are dealing a different beast.
Krishna, can we ask one more question? There's a question for you, Krishna.
Yes, sir.
Yeah, the question is, in what position do you fix that osteotomy fragment after your trials, and in what position of the knee, in what flexion?
So, the osteotomy is fixed in around 30 degrees of flexion for the, because it's a collateral ligament. But the thing is that it actually doesn't need any fixation. It is so stable. That is the thing. You just fix it for your own satisfaction. A lot of the times we've noticed that the entire soft tissue sleeve is intact. So it is usually very stable, and a single screw with ACL washer or something like that, soft tissue washer, is good enough for stability. But if you had a bigger fragment, then you could use 2 screws, but at 30 degrees of flexion.
Yeah, I
once
think
you've done the cementing.
One question, sir.
yeah, the tip is that you save the soft tissue posterior and inferior. I
Yes,
think that's
yes,
the tip.
yes.
Yes,
Krishna.
Deba, you have a question?
Krishna, do you do in all cases of osteotomy, you do subvastus, or in normal cases where you don't do osteotomy, we do only soft tissue release? Subvastus will not be a better approach because we will not be able to have a visualization of the lateral structures. So, what is your opinion?
That is true. So, my go-to technique, as I told you, if you had a type 1 correctable valgus, anyhow subvastus approach. If it was a type 2 valgus, which is non-correctable, we would do an osteotomy with subvastus or a mini-midvastus type of approach. And if it is a MCL deficient situation, then we would look at a more constrained implant. So that is a straightforward thing for me. So I don't do any pike resting or any sort of LCL release in my practice.
Is there another question for Dr. Krishna? Because he has to again board a flight. He has been kind enough to deliver his talk. If there is no question, thank you very much, Krishna, for sparing time at the airport.
I would have loved to stay back.
Thank you, Krishna. Have a safe flight.
Thank you, sir.
Now we can request Dr. Ajith to present his case. Yes, Anil?
Yeah, Dr. Ajith, please.
Yeah.
He's also at the airport, I think.
No, I'm still in the hospital. I'll be leaving shortly.
Shortly.
So I'm just going to share my screen. Bit of an unusual scenario. I was sort of stumped in my surgery, so to say. So, yeah. So good evening. And at the outset, I thank Dr. Anil and Dr. Rajeev, along with the IOA as well as IAA for this opportunity. So quickly coming to the case, this is a 66-year-old lady presented with years of pain and limp. And at this particular point in time, she decided that she needs something doing. So any quick comments on the X-ray? My thoughts were the severity of the deformity, what the status of the MCL would be, what sort of releases I would need, and maybe the type of constraint that I would need. So these were the things running through my mind when I saw her. Any quick comments from the panel?
Mrinal?
I think this is a type 3 valgus, and probably there's a defect in the tibial condyle also.
Yeah.
Once I've cut the tibia, there'll be aberrated femoral condyle as well.
Yeah.
And probably I'll need a TC3 kind of implant once I've done the releases. I would, because the MCL is stressed here.
Right. Anyone else for a quick comment before I proceed?
Dr. Rajkumar is there. I think he has joined. Dr.
Okay.
Rajkumar is there. I think we can proceed.
Yeah, okay. So instead of wasting time, so this is her walking video. She was not using a crutch or a stick, but she was hobbling around like so. So it looks like reasonable stability is there. It's the MCL may be intact. That's what it looked like the way she's walking. That's the flexion she had, and that's the on-table evaluation of the laxity. I thought I felt that the MCL was, there was a definite endpoint. So with that, then these were the thoughts like I mentioned, the approach. My conventional approach is the same as the anteromedial approach. Rarely do any anterolateral approaches or the lateral approaches, so to say. And then the releases all standard, trying to get both inflection and extension, trying to get that, and how to manage the bone defects. That's what the thoughts were. So on table, almost a 40-45 degree valgus there. So on table also, it felt that the MCL was stable. So again, just running through what Dr. Mrinal also mentioned. So the thing is, once I opened the knee, this is what I found. Any quick comments here?
Any comment from the faculty?
There's a fracture there.
Yeah, there is a stress fracture of the posterolateral condyle. And this I was totally unprepared for, and I had not actually picked it up on the X-ray. So now what? With this thing, what to do was the question. whether to scrape out the fractured ends, freshen it, maybe pack some cancellous bone and put a couple of screws and go ahead with the cuts, or remove the whole thing and try to reconstruct. That was the dilemma that I had on table.
Dr. Ajith, can
yes,
we ask
sir.
a question? Was
Yes.
it involving the lateral epicondylar area also?
No, it was not. It was not. I'll show you subsequent slides. It was not. It was just the posterolateral inferior to the epicondyle.
All right, great.
So what would anybody do? I mean, any quick thoughts whether to fix it in situ and do the cuts, or remove the whole thing and then go for some sort of a constrained implant?
I think, Ajith, you can fix it with the temporarily with the K wires.
Okay.
Go on with the routine cuts.
Okay. So that was one option. My thought was to freshen it, trim it, and fix it with screws and then go ahead with cuts. But then I was not sure where my screws would
fixing.
Somebody was saying something?
The fixation with K wire would have an advantage because you can actually take the cuts and cut the K wire which are coming in the way. And that would keep the fixation intact. And then later on, you can actually add the screw if you want to, if you see that the remaining fragment is not stable.
Right.
Yeah.
Okay. So I'll just run through. So whether it was a sponk, it was actually, I think, a stress fracture rather than a sponk. And then the question was how to manage the defect. I was inclined to actually remove the whole thing and reassess and go ahead, because I thought keeping it in situ and freshening it, I may not get a good apposition of the raw surfaces. So that's the defect there. That's after the tibial cut. And excise that and see the amount of defect there. So the standard 8 mm posterolateral wedge would not suffice for this. So you need to somehow build it up. That's just getting my rotations right to make sure that I am on the anterolateral cortex so that my rotations are okay. And see, with the trialing there after the cuts, the distal femur needed a 4 mm wedge, but the posterolateral or the posterior lateral, even with the 8 mm, there was a huge defect. So then the decided to use that same bone graft and then just placing it there, trialing it, making sure that there would be enough bone for me to proceed with the definitive fixation. There, that was with the wedge and the bone graft. I thought if I have enough bone, I would get away without the wedge there. So then use the bone graft that I have taken, fixed it with the small Herbert screws, and then went ahead, only a distal lateral wedge, and the entire, that area was the bone graft that I had taken out. Good tracking of the patella. And then there at the before closure, that's the immediate post-op. That's at 2 years. And that is her range of movement, about 90-95 degrees of flexion that she had. So this was one big surprise that I had on table. So I thought it would be a lesson for people, young, at least the youngsters, to be prepared with all sorts of armamentarium when we do such severe deformities.
So
thank you.
Nice case, Ajith.
Thank you.
Can I just would we as a panel or as people who are doing this regularly give a message out that get a CT done before complex knee comes, when the complex knee, to get these surprises out of the way and plan it?
Yeah, if you find something unusual, yes, why not? Only thing is suspecting it.
Yeah, because X-rays in this case can be very misleading, and I wouldn't have got an X-ray done, CT done in a patient like this.
Yeah, my comfort level was her gait. She was walking quite, as you could see the walking video, she was quite all right. And even on clinical examination, there wasn't any sort of significant pain to suggest a stress fracture. Probably it's been there for months, and the pain part of it had been sort of taken away by the longevity of that stress fracture.
I think the take-home message should be, we should have the constrained implants with the augments.
Absolutely, absolutely.
If it
I
is
think
type 2 or even more than that in the backup.
That is why one need to be more careful with valgus knees as compared to varus knees.
Very true, sir.
You go very well prepared.
That is very right.
That's why this webinar.
A valgus knee needs a much more careful planning than a routine varus knee. Very right.
It is 50% revision preparation.
Yeah.
In a primary knee, at least.
I've for TKRs where I would actually ask for an MRI is where those the condyle suddenly sort of collapses. These are the cases with SPONK. There the condyle suddenly collapses, and that's where you get an MRI to see to what extent that's going and how much sort of either a wedge or a sleeve or whatever you need. That's when I would think of a MRI. But routinely, I've not actually got, other than scanograms, nothing else really.
So great learning, Dr. Ajith. Thank you very much.
Sir.
I know you have to rush to airport again to board
Thank you so much. Yeah.
Today is a flight day, so now maybe request Dr. Rajkumar. Have you joined Dr. Rajkumar?
Good night.
Good night, and have a safe journey, please.
Thank you, sir.
Is Dr. Rajkumar there? Dr. Rajkumar and Dr. Unmesh are together. Dr. Unmesh?
I think Rajkumar was there.
Yeah, he joined for a while. Shall I give him a call?
He's also traveling, or?
Yeah, they are traveling together. Today is a travel day.
So, we are in a resort, so I suppose we'll get some connectivity soon. I think he will be soon with us. So I think we have reached. So I'll ask him to join in a minute. I'll ask Rajkumar to join. 1 minute.
Should we go to the next?
In the meantime, we can have case presentation. Dr. Rajeev is. Or we have one more talk on robotics by Dr. Chandrashekhar. Dr. Chandrashekhar, you are there?
I am ready with my slide. If you guys are okay, I can pitch in.
Yeah, please.
Yeah, thank you.
We'll utilize this time.
Yeah.
You're going to speak on robotics, the role of robotics.
My screen is visible?
No, not yet. You have to share a screen, please.
Visible?
Yeah, please. We go to the slideshow.
Okay. Thank you, IOA, for this opportunity. And I'll be talking on image-based active robots and valgus knees. So alignment and survivorship, whichever alignment you do the better soft tissue balancing. So much of soft tissue balancing has been discussed. Not that just because we do robots, we cannot touch the soft tissue. SOS basis, we need to do the soft tissue. How does the robot pitch in and help us in valgus, severe valgus? I'm going to take you through. And the classification has been discussed. Grade 1, less than 10 degrees and passively correctable with contracture of the lateral soft tissue. And this is most of the 80% of the cases we deal with this. Grade 2 is about 10 to 20 degree valgus with MCL elongated, but still alive MCL. And grade 3, where the constrained implants are the need. So technology adoption is on high. 21% of the surgeries are done through robotics worldwide now. So this is the robot which I am discussing. I use an active robot called Kivis. So we do a preoperative CT scan. Then there is a surgical planning, which is done before surgery. Then we go inside the theater. We open the joint and mark the knee. The CT points, what you have done on the pre-plan and what you mark on the patient knee gets compared. Then there is a gap check, which is done. You can either go for a modified resection or a modified gap technique. Then you ask the robot to do the milling, and then you do the final gap and implant. So this is how the pre-plan is. To do the hip center, knee center for the mechanical, condyles for the epicondylar axis and the posterocondylar axis. You see the implant in 360 degrees, matching the posterocondylar medial and lateral symmetry. You see how the implant looks in middle-laterally. Basically, you shape match the femur, but this is a static plan. This doesn't mean that you cannot do any dynamic changes on the table. This is just helps in the implant positioning, both on the femur and tibia. The planned result is taken on the pen drive and loaded on the robotic machine. So again, I'm reiterating, this is a static plan. You can change everything as per the soft tissue needs on the table. So these are the three parts to the robot. First is a main console, which is used to capture the knee anatomy. It's a navigation camera. Then there's a robotic milling arm, and then the software planning. So these are the benefits of CT scan, which there sometimes we can see if any surprises are there, stress fractures. We can see the implant position, patellofemoral rotation. You basically know the implant sizes. You can minimize your instruments in the OR, minimize the assistance in OR. Virtually the surgery is done before going to the theater. Sagittal implant position, you can flex or extend the component, and then you see how the gaps changes. Since it's an CT-based robot, we don't do hip marking or malleolar marking. Sometimes can be erroneous. That is an advantage in image-based robot. So comparison of the CT scan, what you mark on the pre-plan gets compared on the real time. So any alignment you can do, mechanical, functional, and kinematic. Since you are sticking to valgus, it's more to do with the mechanical alignment. I don't do functional or kinematic in this. And sometimes missed talus lesions can be picked up with the CT scans. So these are the benefits of the CT. This is the marking, what we do. These are the femoral arrays, femur and the tibia. This is just the marking video, how we mark the both the femur and tibial anatomy. This is the patient which I want to discuss. This was done in the morning today. She has a valgus knee. And as Dr. Ajith told, we can also do the stress test and see before we start the surgery. So this is the preoperative walking. This is a pre-op X-ray. It's a valgus knee. So these are the intraoperative options which are available for you, and which you can use it. And this is the extension gap. If you see now, if you see the left side image, so the distal cuts are 2.6 and 7, basically 7 on the medial side, 2.6 on the lateral side. This itself should help us in the extension medial tightening releases, because there is 7 mm cut. The gap opening is 3 and 10. 3 and 10, basically the plastic size is about 13 and 20. Tibia is planned about 5.1 and 5.8. If you see the top corner, the C is the femoral implant which is chosen. The rotation is 0 to the transepicondylar axis. It's a mechanical alignment, whereas is 0 degree. The component is kept at 0. This is the pre-plan. So the limb is showing -5, hyperextension with a 9 degree valgus. If you see the second and the third image, one which is taken out with the stress 8 and 6, what was 10 and 3 has become 8 and 6. That means the extension may not require any releases because it's a correctable valgus in extension. And if you see with or without stress, both the screens are seen in the screen 2 and screen 3. Then you see the flexion gap again with or without stress. So with stress, it's 13 on the medial side. It says that your flexion medial is quite loose. That means MCL is elongated. The flexion lateral is 7 with or without stress, not much variation. If you see both the slides, it's 7 and 8 and 13 on the medial side. So this is gap plan is done without stress, where you do the gap plan without stress, and you see these are the changes I have done. If you see the top corner, I have shifted the implant couple of millimeters posteriorly. I have internally rotated the femur to 4. That means I had kept 1.8 degree to the PCA. Now it is about 2 degree internal rotated to the PCA. I have flexed the component to a couple of degrees. Now you see the balancing. Now it is 10 and 10 and extension medial and flexion medial. Extension lateral is 5 and extension lateral is 8. If you see the bottom corner, so I may or may not require release, but I know flexion is taken care. It was 13 and 8. I have made it to 10 and 8. This is gap planning without stress. Now again, you see gap planning with stress. If you see gap planning with the stress, you see the right side picture. It's extension medial 8, flexion medial 8, and extension lateral is 6, and flexion lateral is 5. These are all done without any cuts. This is just before the cuts. It's a pre-plan. It's a dynamic pre-plan. You do with stress, without stress. So basically, I know there won't be much releases in this because extensions 8 and 6 is almost balanced out. Flexion is 8 and 5. Let me go ahead and see how the post-operative checks are. So what are the options which are available on the table? So once you do the marking of the knee, then you get to know whether your knee is extension and flexion, both valgus and correctable. No release are required. Suppose you have an extension valgus and a flexion valgus which are non-correctable to stress test. That means some bony adjustments you can make, but everything cannot be done on the bony adjustment. You may go for releases. And this has been extensively now discussed by Manuj and Krishna with epicondylar osteotomy. Extension correctable with stress and flexion non-correctable to stress, then you can do rotation of femur. That means your flexion medial is loose. You can play a couple of degrees of rotation. It makes a huge difference for a stretched MCL and a tired MCL. Internal rotation helps us to cut less bone on the flexion medial says. So you avoid the releases on the lateral side. You're correcting the bony component. Extension non-correctable to flexion correctable to stress, IT band release. Extension valgus and flexion varus. Some knees are extension valgus and in flexion varus, there is no need to change in the rotation. You can just balance the lateral side once all the cuts are made with IT band releases if required. So this is the dynamic joint balancing, which helps match the bony landmarks and preoperative CT. Joint gaps post bony resection is calculated before bony resection, adjusting the bony resection lines to obtain ideal joint gaps, post-operatively well-balanced knees. So this is the small surgery which we did today. So this is how the knees are checked. It's just a bit faster video. And this is how the joint is mapped. First, this CT markings gets compared with the what you mark on the patient's knee. Then if there is any error of marking, it shows because you are basically marking the patient's knee. There is no 3D creation of the image because it's a CT-based robot. Once all the markings are done, then the plan is already loaded on the robot. You do a dynamic gap checks, what I told you at 0, 30, 60, 90, 120, and play the bony adjustment. But as I've told you, just to get the MCL tight, you can't internal rotate for 7 or 8 degrees. Couple of degrees is okay, but it plays a huge role. This couple of degrees tightens the MCL because you don't cut much on the posteromedial side. So it helps in avoiding the releases, especially because it's very unpredictable to release the popliteus and the LCL for the flexion tightness. Yes, for extension tightness, a good IT band correction will do the needful. If it's a fixed valgus, the game is different. You can do the posterolateral capsule or the inside out technique as defined by Ranawat. So this is an active robot. The cuts are done as per your prerogatives, and then the plans are done, pre-plan. Then there is a dynamic gap check. Then there is an adjustment. Then the knee you see both in stressed and without stress. Then you balance your unaffected side. Go ahead with the cuts. Finally, when all the cuts are made, again, you see with the spacer how the implant looks, both in flexion and extension at 0, 30, 60, 90 at trial implants. You can see with the gap balancers, and then you go ahead with the proceeding of the implant. So once this cut is done, just fasten the video. So these are just the cuts. Once the cuts is done, then you go ahead with the final checking. So this is how the robot cuts. I do all the cuts on the femur and the tibial side. I use the robot only for the cut, but the sizing and the rotation is mine. I leave a couple of millimeters of bone posterolaterally for the safety. This is how the gaps are checked with the gap spacers, both in flexion and extension. Yes, this sometimes the power, how much we use it, it's difficult to elicit. So you can do a trial implant and then see this is the final gaps. So the same knee which I showed. So the valgus is 0 degree now. The limb is at 3 degree because it is an hyperextension knee. This is how I check the gap. I check the gap at 0 degree, 30, 60, 90. If you can see the screen, it is 10, 9, 9, 9, 9, 9. So at every angle at 0 to 130, you can see the stability, you can see the numbers, you can see the laxity. So this knee basically we got out without any releases because we did only the bony corrections. And this is the final clapping of the same knee. This was done in the morning. This was again after the repair. This is one of the paper we presented in the Indian Journal of Orthopedics. The active robot is quite safe. It leaves a bony island. Whatever you have planned, it cuts less than 5 millimeters, less than what you have planned. So it's safe. So this is the pre and post-operative X-ray. And thank you so much. And we'll be happy to answer any of the questions.
Thank you, Dr. Chandrashekhar.
Dr.
Any question for Dr. Chandrashekhar?
Chandrashekhar, if I can ask you, would you like to give one message which brings the robotic over and above the conventional surgery?
The one is you have the medial and lateral laxity with and without stress, number one. Number two, imagine a situation where you have a flexion medial loosening because the MCL is elongated and your extension is well balanced with the stress. These are the cases where you can rotate internally femur a couple of degrees and totally get away with an popliteus or an LCL release or even an epicondylar osteotomy sometimes.
Okay, sir.
Number one.
Number
sir,
two. You can take the mobile. I'm not using it because I'm using
So practically what you are suggesting, Chandrashekhar, is that this does reduces the amount of soft tissue release that is required.
Yes. And number two, suppose there are many knees which are distally hypoplastic, posteriorly not hypoplastic. There are some knees which are posterolateral hypoplastic, may not be distally hypoplastic. So you get to know all this by doing dynamic gap changes on the table. So I personally feel the soft tissue can be less utilized. As couple of degrees of bony changes, 2 to 3 degrees of mild internal rotation. I mean, I'm telling internal rotation to the PCA a couple of degrees, not to the TEA. This helps in so much of need for extensive releases on the lateral side, both in the severe varus and severe valgus knees also. In the severe varus, I do functional alignment where I keep my tibia to a couple of degree varus, which obviates the need for most of the soft tissue release in the 90% of the cases, even with severe varus knees, where I go for functional alignment with couple of degrees varus on the distal femur, couple of degree varus on the tibia, and play a little bit with the rotation. And then this is the game. And then you don't have to do most of the times releases. So in the severe varus, I do functional alignment. In a valgus, straight away mechanical, because I can't put my tibia into varus. It's already medial side is loose. So obviating the need for soft tissue releases. Yes, these couple of degrees might look very, very silly, but on the table, it all avoids the unnecessary soft tissue release. And that's where I feel robotics or computer technologies are definitely helpful.
All right, yeah. Thank you so much. Any other question to Dr. Chandrashekhar?
Dr. Unmesh has joined. Dr. Unmesh.
Yes. Basically, I use robotic as well.
I think that there's some network issue.
Dr. Chandrashekhar, can you unshare your screen?
Is quite important.
1 second. Yeah.
As he mentioned, internal rotation of the femur is very important to decrease the releases, and it really gives good correction in robotics in type 1 and 2 deformities. That's what my own experience with the robotics are. So that's very important to get robotics in the valgus knee, and quite easy to do that. Thank you.
And Dr. Chandrashekhar, what % of cases you think you have now stopped releasing? Earlier, you were releasing the valgus knee, and now with the advent of robotics and your use with robotics.
Type 3 valgus, where you have fixed deformities, everything you can't correct with one. You can't have a 5 to 6 degrees internal rotation and have a patellar mal tracking. Yes, these are very subtle. And as you know, sir, 80% of the knees are most of the time grade 1, grade 2. Knees, and very less 10%, 15%. Yes, you need to be flexible as a surgeon, can't be rigid and saying that I do robotics, I don't release. No, there are very severe varus. You may end up some releases on the medial side, but the decision, it obviates the need of release, and you titrate the release as per the need on the table. You don't release because you do all the cuts and then go ahead with the release as per the need. And couple of degrees of tibia varus, mark my point, sir, it obviates the need for a lot of soft tissue release on the medial side in a severe varus knee. And you would love to do most of this valgus knee with robotics, because the small rotation game what you play ultimately obviates the need of this MCL laxity. Once you take, for example, you go blindly on a conventional knee and then do a 3-degree rotation, it's very difficult to assess the flexion medial looseness, and again you will end up releasing on the lateral side. Number one, yes, a smart conventional surgeon is as good as a smart robotic surgeon, according to me, because robotic surgeon has the numbers on the play.
So that's an important message, that release must be done whether as per requirement.
Yes,
for that
yes,
particular
as per the
patient.
requirement.
Very right, yeah.
Not that every case you don't release, but you can reduce the release, and release can be taken as a last option, and once you remove all the osteophytes. So that is something which is helpful on the robots.
Thank you very much. I think Dr. Rajkumar is ready with his talk. Dr. Rajkumar has joined.
Yeah.
Please.
Good evening, everyone. Sir, can you hear me?
Yeah.
Yes, we can.
Good
Loud and clear.
Good evening. Thanks, Dr. Rajeev, and thanks, Dr. Arora, for this invitation. Sorry, I'm doing through my mobile phone as I'm trying I'm using the hotspot. Internet connection is very much intermittent, but I will try to keep it as quick as possible. So, coming, can you see the screen now?
Yes, please.
Okay. So, yeah. Okay. Coming to the topic straight away. So, that was a wonderful discussion going on in the valgus knee, and almost all the points has been covered. So I will keep it little straightforward and lateral parapatellar approach, how to be done and how I have done for this case. So this is a 40-year-old rheumatoid arthritis. So she has underwent left side a THR 6 years back, and then right side a THR 3 years back, and also left side total knee replacement. So this is now the plan is for the right side total knee replacement. These are the X-rays of both the hips after THR, and then left side TKA done. So if you look at this X-ray, the patient has got a severe valgus deformity, and bone is very, very soft, osteoporotic as it is expected in a valgus rheumatoid knee. The lateral compartment is badly damaged. And if you look at the lateral view, you can see the joint is so much, in the lateral view, it is subluxed. The patellofemoral arthritis is very severe. It's almost stiff, and in the skyline view, it is almost dislocated. It's like grossly subluxated, and it is not at all articulating in the correct place. So it's quite a complex situation in this kind of scenario. So the plan is to go ahead and do a total knee replacement, and as I always do in all the complex situations, took a stress view, and if you see the stress view, it is partially be correctable, but still more than the partially correctable thing, the patella situation, the almost a dislocated situation, made me to think whether to go ahead and do a medial parapatellar or a lateral parapatellar arthrotomy. So the difficult points here is 40-year-old rheumatoid osteoporosis, bone loss on the lateral side, severe valgus, patella almost dislocated. So if we go ahead and do a medial parapatellar arthrotomy in this situation, then definitely this patient will need a lateral retinacular release to bring back the patella. There might be situations, or some surgeons might be able to get away with the medial side. I accept, but still it will be a very, very challenging situation, because a small female patient, thin individual, immunocompromised patient, if you're going to open it on both the sides, then it puts the patella into a lot of jeopardy of avascularity, soft tissue problems, and difficulty in getting the wound closed. So in looking at all these things, then I decided to go ahead with the lateral parapatellar approach. So my algorithm for a valgus knee is almost always it is a medial parapatellar approach. But if the valgus is a fixed valgus, then I don't hesitate to use a lateral parapatellar approach. It makes the life still more easier. So after a midline incision, this is how the knee was looking. So you can see that the patella is almost out of the trochlea, and it is lying very much lateral. So in this situation, I definitely decided to go and do a lateral parapatellar approach, and this is how I took the incision, totally going into the lateral. The key point here is, in a lateral parapatellar, you have to identify the patellar tendon properly, and then go ahead and take the lateral parapatellar approach. But make sure you are not excising the soft fat pad and also soft tissues as we do normally in a medial parapatellar. So the moment you do and excise so much on the lateral side, then again the wound closure, the coverage of the implant becomes very difficult. So this is how slowly, gently dissect it across, and then I went ahead and did the lateral parapatellar, and you can see the moment I did a lateral parapatellar approach, the patella almost went back to the position. So this is how, even without proceeding to the procedure, the lateral arthrotomy itself corrected the patellar the dislocation. So that was the big advantage with this approach. even though it has got its own disadvantages, but in this particular situation, I felt parapatellar approach very, very helpful. Then after that, so you can see the patella when it was everted completely, it was excavated. Such a big depth of patellar excavation was there with severe osteophytes. So definitely it needs a patelloplasty. So after I did the patelloplasty, this is how the patella was looking. So then after that, then slowly I was able to get the patella away. And this is a big challenge in a lateral parapatellar approach. Even in a fixed valgus also, whenever you do the arthrotomy, it is not easy to take the patella entire extensor mechanism to the medial side. So that is the challenge, but you have to be gentle, make your way through, and slowly do all the releases on the suprapatellar region so that you are able to retract towards the medial side. So try to do that as much as possible. And then the next challenge will be to get your midpoint. So that is also, again, in a normal situation, in a medial parapatellar, it will be the tibial tuberosity will be very much visible, but here it is covered with the patellar tendon completely, trying to mask your midpoint. So you have to be very careful and place the pins correctly so that you are able to take the tibial cut properly. So the another important point to note is your saw blade has to be protected from injuring the lateral extensor mechanism. That is again the next important challenge we face in doing a lateral parapatellar arthrotomy. So you have to be very careful. Once that is done, then rest of the things becomes a routine. So here in this situation, small female, very, very soft bone, I used a small tray, 1.5 tray, and after taking the cuts, after taking all the cuts, trying this is the trial, the smallest femur, 1.5 femur, 1.5 tray, and you can see that without any additional releases, the patella is tracking well. So that was the big advantage of this approach. If I had used a medial parapatellar approach, then I would have definitely I would have opened it on the lateral side as well. So 2 openings in a small patient in a rheumatoid knee, it becomes more complex. So this is how, after the implantation, after cementing the original processes, the tracking was again good without any additional releases or plications. So after this, the tracking was very, very good. So medial plication was done so that the soft tissue heals, and then the tracking becomes very good after the closure once the patient starts the ROM. So that was the medial plication, and this was the immediate post-operative X-ray. Patient knee brace was given, mobilized with walker. The problem started in the POD3. So this is again another problem you will encounter in a lateral parapatellar approach. You have to be gentle. So the moment this happened, because of the complete lateral release of the lateral opening, the hematoma forms, and then it puts tension on the lateral soft tissue. So that has to be given sufficient time. So you have to be very careful. So in this scenario, once this was there, I had to stop all the mobilization, stop the anticoagulants, wait for some time, allowed the soft tissue to heal. Antibiotic was started. 2 weeks later, slowly then the situation improved, the tension on the lateral aspect reduced, and the wounds started to settle down. So this was the 3 weeks post-operative X-ray, and then the skyline view was done. Till that first 3 weeks, I didn't do the skyline view. I didn't want to put stress on the extensor mechanism. So after 3 weeks, the wound started to heal, and then the patient went on to do well after the procedure. So the whole point here is the need for lateral parapatellar approach in a valgus knee is very, very less. Most of the time, 95% of the time, you can get away with the medial parapatellar. But these 2 situations, in this situation, the patella was completely dislocated. That was one situation. I did a lateral parapatellar. The next, another important situation where I go for a lateral parapatellar is a fixed valgus. Even in spite, after anesthesia, if the valgus knee is not correctable, even partially not correctable, then I would prefer a lateral parapatellar arthrotomy. Thank you.
Thank you, Dr. Rajkumar. Thank you very much. So,
thank you, Rajkumar. I think the one point that you have mentioned very well is that there is more bleeding in the lateral parapatellar approach, and that is what we should, everyone should know very clearly. Rajkumar, would you agree that when you need a tibial tubercle osteotomy, then a lateral parapatellar approach is rather more useful?
Yes, I definitely agree with that. So that tibial tubercle osteotomy and the lateral parapatellar approach is very helpful whenever you want to shift your quadriceps extensor mechanism more medially. Then that definitely it really helps. But in this situation, I didn't want to do that because she's already rheumatoid, very thin individual, osteoporotic, and already the patella is dislocated. So in this situation, if I go ahead and do a tibial tubercle osteotomy, and if it puts a lot of stress on that bony component, and if any issue with the healing, then it'll become a big problem. So
yeah, what I wanted
way, in
to
this
point
case,
out, Rajkumar, is that when you do a lateral approach, lateral parapatellar approach, the subluxating the patella on the medial side is more challenge, and that's why we could see that you had given a long incision in this case. That's very rightly shown.
So good evening. I'm Dr. Deepak Inamdar.
Yes, please.
Dr. Rajkumar, 2 points I would like to tell you. I recently did a similar fixed valgus. One, to prevent the wound complications, you can do a coronal Z-plasty. So a coronal
Z-plasty of the quadriceps?
Not the quadriceps, the retinaculum on the lateral aspect of the patella is split transversely, and it's opened up. You can look up about the coronal Z-plasty. It's a lot of papers are there. So it opens out, and you can stitch it side by side, as a result of which you can cover the implant very well. I think I'll present it the next time in this IAA. So all of you can, it's a very nice approach for lateral approach for all valgus knees. The second thing, instead of your tubercle osteotomy, which if you feel it's too complicated, I think a simple rectus snip would have been, will give you a lot of adequate exposure.
I think both the suggestions are very good.
Valid. So here quickly, I accept that that coronal Z-plasty, but here I didn't have any issue on the wound closure or
see, you will get a very airtight closure if you do the coronal Z-plasty, just like how you do in the medial side. You create.
That's a good point, Dr. Inamdar.
Yeah. So it's a fantastic.
One point that we must make sure here is that there is a more bleeding anyway in a lateral approach than a medial approach. Dr. Anil, should we go on?
Yeah, I think we should, because
in the interest of time,
2 more cases are there. And I think, Dr. Rajkumar, would you like to convey this message that after this approach, we have to go slow on rehabilitation, or we go regularly the way we go?
Very much. As Dr. Rajeev said, because we are opening completely on the lateral side, it puts a lot of bleeding completely into the subcutaneous level. So it puts a lot of tension on the soft tissue. The wound healing can be a problem. So you have to be prepared. If any need, sometimes even a plastic surgeon's help might be required. So you have to be a little careful, go slow, stop all anticoagulants, but don't be in a hurry to do anything extra. Wait and watch. In this situation, it took 10 days to 2 weeks for the wound to settle. So it needs patience.
Thank you very much. Thanks a lot.
Thank you, sir. Thank you.
Can we request Dr. Kalia to present his case now, please?
Yes, sir. I'm ready.
Yeah, and Anil, maybe I can take my pointers at the end of the webinar.
Yeah, yes, sir. You have to give us take-home pointers.
Is my screen visible?
Yes, it is.
Okay, so after such an extensive discussion about windswept knees is something which is also an interesting case. And so this is the lady, and it has got a rheumatoid knee with foot deformities as well as knee and a pretty bad kind of valgus. Okay, so these are the clinical scores. VAS was pretty bad on the left side, and Oxford knee was pretty bad. This is the radiograph. And here you have a medial laxity as well as a huge tibial defect. So you need to be careful with this because you will need to take care of both of them. And she's a rheumatoid with pretty bad bone quality as well. This was our pre-op planning. We do it with a digital software. And this is a long leg film of the same patient. And again, the same thing that there is a pretty huge medial laxity. So this is the kind of angles we measured. And there's a 35-degree valgus. And despite this valgus, so the planning that we have is, again, the same thing. A lot of discussion has already happened. So which approach on the left side, which implants to be arranged, and how to manage the bony defects, and when do you add a stem? So any of the faculty would like to, I think approach has been dealt.
Yeah.
Implants probably, yes.
Dr. Kalia, in the interest of time, maybe we just go on presenting and then we can have a discussion.
So these are the questions that come to your mind. And so this is what we got when we opened it up. We had a massive defect on the lateral condyle. We reconstructed that with a bone graft and screws. And we had a very huge medial laxity, despite having taken very small cuts. And even with the TC3, we could not manage the flexion instability because there was a huge flexion instability. And with a very large poly also, it was very unstable. So we used a hinged rotal knee and we did a posterior stabilized on the right side. So these are the intraoperative images, pretty straightforward. And this was how the hinge looked. And this is the post-operative radiograph. And we had to use a pretty large poly even after putting a hinge. So that tells the whole story that it was very, very unstable. And we were talking a lot about tightness. Here it was like a globally unstable knee that we had after we had done very small bony resections. So the story starts after that. We were happy with that. At 3 weeks follow-up, there was discharge from the left knee and the right knee was recovering well. And this is the situation that you have now, that you have a swelling over the left knee and there's a gaping of the wound and there's a discharge present. So on examination, we find that there is extensor lag, and to a surprise, the radiograph shows a tibial avulsion. So there is an avulsion of the patellar tendon from the tuberosity. And so next, what came to our mind? Should we debride first because there's a wound problem? And do we do the repair then, or we do it in a staged manner? So we decided to do it at a single setting. And this was the diagnosis, patellar tendon rupture. And we did a patellar tendon repair with encirclage and wound debridement. And the intraoperative findings were, we had a patellar tendon avulsion. And it was not just an avulsion. There was a huge rent in the lateral retinaculum also. And the whole of the medial capsule repair had failed. So we did a transosseous repair of the patellar tendon using non-absorbable sutures. And then we used an encirclage wiring. That was also a challenge because now we had a patella which has been replaced. And it was extremely difficult to pass a wire through the patella. So we used a wire through the superior pole of the patella, not through the bone. And the polyethylene liner was changed and antibiotic stimulant beads were inserted. These are the intraoperative pictures. And to highlight the stretched out poor soft tissues, which sometimes are a huge problem. And despite being very careful about it in the first instance, we still had an almost complete rupture of the whole of the extensor mechanism. Not only that, there was a rent in the lateral retinaculum as well. So that tells the whole story that how bad the soft tissue must have been. Anyhow, this was what we did. And this was the post-operative radiograph, which shows the patella in the right place and the stimulant beads. And we landed up with a happy situation because now we have the patient at 2 months. We were very slow with the rehab. We went very slowly. And surprisingly, we could still achieve a great result. So she is walking at about 2 months. And surprisingly, there is no extensor lag. So this is a message we want to share, that sometimes complications are also there, and you need to very effectively take care of complications. So the take-home message from my case is valgus knees in rheumatoids is not a simple cakewalk. There is no simple cookbook recipe. Be prepared, and laxity can also be a major issue. One way to deal with it is take the minimum possible bony cuts, and it is extremely important to take the patient into your confidence and counsel them carefully. That look, this is not a straightforward case, and there can be many complications that you can't predict. Infection is one of them, and you need to be careful about that. And even soft tissue complications and laxity and other things can happen. So you need to be very careful about it. Thank you very much for the opportunity of sharing my case.
Thank you, Dr. Kalia. I think it's a very interesting case. The few points, if I can make, the one is that soft tissue handling in these severe valgus is very important. The second is that if you have a rupture of the ligamentum patelli, if it is a partial rupture, it usually recovers well if you have sutured it well, bony suture, using the anchor suture, or the tendon has been fixed with the bone. Then usually the results are good. And you're rightly mentioning that infection is a major issue in all these cases.
Yes.
Thank you so much. Any question for Dr. Kalia? Anil? If not, then maybe we move on to Dr. Mrinal's case. Mrinal?
I have a question for Dr. Chandrashekhar. Can I ask now?
Maybe now we can take it up after at the end of the webinar, in the interest of time.
No problem. Right. Thank you.
Thank you so much.
Yes, Mrinal.
Mrinal, you are on mute, please. Mrinal, unmute yourself.
No, okay, sorry.
Yeah.
So can you see my screen?
Yeah.
Yes, we can.
Visible.
So I'll be sharing a case a little different from the ones which have been presented. It's a valgus with an extra-articular deformity. It is also a rare occurrence, but it can be a problem. So this seems to be a very normal looking X-ray for everyone. 57-year female had a road traffic accident 15 years ago. Femur and tibia both were fractured, and she got them plated. The plates have been removed subsequently over the period of time, and she presents to me with pain in the right knee. She has a valgus thrust on walking, and the parameters for infection are all normal. This is her clinical pictures. So clearly she has a valgus in the right knee. And the lateral side also, you don't find much of the deformity in the sagittal plane. And this is the video of her walking. You can see she's walking with the valgus thrust. Clinical assessment shows that the deformity is correctable to a small extent, but not completely. These are her X-rays now. And you can see there is a malunited fracture of the femoral shaft, and also a malunited fracture in the metaphyseal region of the proximal tibia, with the fibula fracture also at that time. There's little bit of hyperextension at the fracture site on the tibia, but if you see the femoral side, it is angulated in the sagittal plane. So there is a bowing in the femur, which we will obviously need long X-rays in such a case. So this is where the importance of orthoscanogram lies. And you can see here that she has a bowing on the lateral view. If you see the orthoscanogram, she has a bigger bow on the sagittal plane of the femur as well. And what we need to assess is that she has a valgus angle of almost 11 degrees. That means the femoral fracture is also united in a little bit of valgus. That is also contributing to the increased valgus angle. And if you see that the anatomical or the mechanical axis of tibia is actually cutting through the condyle. So it's cutting between the condyles. According to the Wang's principle, that gives you an idea that probably you might be able to correct it intra-articularly. And the angle of the tibiofemoral angle here of valgus is 20 degrees. So this is what we need to take care of in such patients with extra-articular deformities. So it's a dual deformity. It's a biplanar deformity with corneal and sagittal deformities both. We need to see whether we'll be able to correct it intra-articularly, or you might need an extra-articular correction, for which you should be prepared with the plates and also long tibial and femoral stems. Some might like to do it in a two-stage. Single stage correction is also done by a few using robotics and navigation, whatever you might need to use. And you must always keep the constraint prostheses ready in dire situations where you might not be able to balance them. So I used navigation in this patient, almost done 2 years ago. This is the brain lens system I'm using. You can see that there is a defect in the tibial condyle, and I've done the routine cuts of distal femur and prepared the femur. And the tibial side, you can see I am hardly cutting any bone from the lateral condyle of the proximal tibia. And just 4 millimeters of the bone was removed from the medial side of the tibial condyle. And I did the routine balances and achieved good amount of extension balance, releasing the IT band and the posterior lateral capsule, and also by releasing the LCL and pike crusting of the posterior lateral corner, I could get a flexion correction also. And these are the post-operative X-rays. So if you see this X-ray might look a little skewed to a lot of people, but actually with the navigation, without any corrective osteotomy done, I could get almost 0.5 degrees of, it's showing a valgus on the correction navigation report, but it's almost like a neutral alignment. It does show you the flexion in which the limb is. That's because of the bowing of the femoral shaft, which is there in the sagittal. And you can only correct up to maximum of 8 to 10 degrees during the with the total knee arthroplasty in an extra-articular deformity in a sagittal plane. So that is an important point to remember. You can't correct beyond that, because if you try and extend that, you will be having femoral notching on the femoral side. And you can't extend, you can't reduce the slope of tibia also beyond 3 degrees. So that is also very important. So you can get maximum 4 to 5 degrees of extension in the femur, and reducing the slope of tibia, you might get 8 to 10 degrees of correction, not beyond that. Beyond that, you need to do an extra-articular osteotomy and then correct that. But sagittal plane deformity doesn't have much consequences on the results after total knee arthroplasty, because it's in the plane of the movement. Corner plane deformity needs to be corrected, which has been almost been actually, we've reduced it back to normalcy. So if you see these X-rays in 2 years follow-up, and this is the video of the patient walking, and she's having a perfect result. She's from a distant place. She's not following up, but she's been sending her X-rays and videos to me. She's doing well. So the key learning points would be that orthoscanograms are a must in such deformities, where the normal X-rays would not be able to tell you about the deformities in both the planes. Navigation and robotics are very helpful. If you have them, must use them. The nearer the deformity to the joint, the larger the effect of the deformity on the, the nearer the deformity is, actually, it has a bigger impact. Intra-articular correction can be done if the corneal plane deformity is less than 20 degrees in the femur and less than 30 degrees in the tibia. And that too, when the cora is located outside of the metaphysis. So that's a very important thing. If the cora is in the metaphysis, you will not be able to correct it intra-articularly. Follow the Wang's principle, which tells you that less than 30 degrees of extra-articular angulation in the tibia can be corrected with intra-articular correction of the alignment if your anatomical axis passes through the condyles of the tibia, and if it is not cutting onto the attachments of the collaterals on the femoral side. Malunions more than 30 degrees are to be corrected by extra-articular osteotomy and fixation beforehand or during the surgery. Sagittal plane deformities are generally better tolerated by total knee arthroplasty patients, and a FFD or a flexion deformity or in the sagittal plane of less than 10 degrees or a recurvatum deformity of less than 20 degrees is amenable to correction by intra-articular correction. Any greater deformity must be corrected with an osteotomy beforehand. So that's the key learning point with this case, and it's open for discussion.
Thank you, Mrinal. I think it's a very interesting case. more so because you have corrected the extra-articular deformity within the joint. Now, one burning question here will be, I'm sure with most of us, that the tibial cut in this short X-ray that we see is showing as if it is in significant varus. Right? But obviously you were doing it with the navigation, and on a long film, you must have realized that it is okay. It is that.
On a long film, it's fine, but I don't have that. But on table also, we got 0.5. I have shown you the navigation report. That is all I could find in the navigation report with me available right now. That it's almost 0.5 degrees of valgus. So rather the tibia showing is a varus, but actually it's in the alignment is in 0.5 degrees valgus. So that's been that was on table. So maybe it's like a kinematic alignment where the soft tissue sleeve has been balanced. In a valgus, the alignment has been brought down to normal, but the implant shows in a skewed position. Even if you see the femoral component, it seems like that it's hyperextended, but that is because of there is a deformity in the sagittal plane also. But the patient is having a good function. She is walking well, and the alignment is perfectly maintained. So we'll be happy to see the long-term follow-up of this patient. If there is any other question, then maybe in the interest of time, I'll, Anil, what do you say?
Yeah, just one.
Do you have any question?
What limit will you put to tibia varus? To what extent will you go? How many degrees?
Maybe 3 to 4 degrees, not beyond that.
Not beyond that. Yeah, thank you. I think, Dr. Rajeev, you should now give us the final take-home messages.
So
yeah, I'll be quick in this.
Can I ask a question, please?
Sure. Please.
Yeah, this is for Dr. Chandrashekhar. I hope he's around.
Yeah. Sure. Now you can ask, please.
Yeah.
So, Dr. Chandrashekhar, in the robotic surgery about valgus knees you were telling, so how many have you used the lateral approach, number one? If so, where do you put the trackers, number two? And what, after using your in robotic surgery, how much has it reduced your lateral release? So all the three, could you please answer?
Fantastic question, doctor. Fantastic.
It's a lot of questions for you, Chandrashekhar. Yeah.
Fantastic question. See, the robot which I use, they have a set pathway because how the medial cuts are made, all the medial cuts and the tibia are made from anterior to posterior. The lateral cuts are made from side to side. Yes, for a lateral arthrotomy where you might have to do in some fixed valgus, these robots cannot be used because I have to have another pathway, but we can develop that pathway where in the lateral, wherever we do the lateral arthrotomy, the cut has to be for that. The lateral cut will be anterior to posterior. The medial cut will be from the side to side. But as of now, this cut pathway is defined for the medial parapatellar arthrotomy, where the medial cut goes from anterior to posterior, the lateral goes from side to side. So for the lateral arthrotomy, yes, they can change the sequence. It's not a big scientific but can be done. But it is an excellent thinking and an excellent question. Number one. Number two, my flexion valgus releases have come down significantly because the dynamic balancing very clearly suggests whether your knee is also valgus in flexion or it is neutral or varus. In cases where the varus, I just go ahead with 2 to 3 degrees of external rotation. If it is neutral, I can see that dynamic joint balancing with the spacers, then decide how much degree of rotation. I don't stick to 3 degrees, sometimes can be 1, sometimes can be 2, because this hypoplasia, which bears out of the distal hypoplasia, not always that they have a posterior hypoplasia. The secondary flexion valgus is because of the defect in the tibia, which mimics the secondary flexion valgus, and that valgus gets obliterated once you do with the spoon or the spacer in the tibia and do a dynamic balancing. You don't have to rotate internally the flexion. So these small things of 1 or 2 millimeters does vary a lot of difference, because when you start doing navigation or robotic, you'll find out that most of the valgus can be only in extension, and in the flexion it is secondary valgus due to tibial defect. And once you put a spacer or a stress view, this valgus gets obliterated. So then you don't need to do any releases in the flexion. So yes, in fixed valgus, with severe deformity, robot can't bail you out only with the bony corrections. There has to be some corrections which has to be done, which I've already explained. So 100 robotic knees, to your question, 100 robotic valgus, 80 to 90% of the time, the simple knees, I do get away without any releases. The maximum release I do an IT band at the mid joint level where I resect it partially or totally. Okay.
Thank you so much, Dr. Shekhar.
Thank you so much. Yeah.
Yeah, thank you so much. So now we are already about 14 or 15 minutes beyond our time. So I'll be very quick in discussing the take-home pointers. To begin with, Anil, I like to show that there's one case.
Yes, please.
I hope you can hear me and see the slides.
Yeah, clear.
Okay, the one case where you have a valgus knee on the left side with a patella which is subluxating. And this patient was operated elsewhere by this implant. And in the interest of time, I'll just quickly mention that what are the things that we found out, we realized that are little not correct here, is that varus cut in a valgus knee is probably a absolutely no-no. Because if you do a varus cut, you will have to release a lot on the lateral side, which is not right. And also the rotation of the femur is very important. Because if you have a rotation of the femur, that's what you see, the patella is almost subluxating, even in postoperative skyline view. And there is an attrition of the patellar bone because it is hitting the lateral edge of the femoral component. And the other thing is that this patient is almost having a partial rupture of the quadriceps. And that's what is seen by this dimple that she has. And it is very difficult for her to correct, to extend the knee from flex position. So probably these are the simple things which we can look after in the right way. And then we see we have already discussed that which classification to be followed. We must decide whether the deformity is intra-articular or extra-articular. If there is a wear only of the bone or the cartilage, just do the soft tissue release and an unconstrained implant is enough. If you have a severe contracture on the lateral and posterolateral side, then these are the cases where you need to have the semi-constrained implant with you, or you be ready for a lateral epicondylar osteotomy in these cases. Where you have an elongated MCL, there you have to be more prepared and be sure that you have a hinge ready with you. And when you have an extra-articular deformity, as it has been shown by Mrinal, probably it is right to be prepared with the extension stem and a constrained implant. Which approach we have discussed very clearly. Dr. Rajkumar had shown the lateral approach. Mostly the anteromedial approach is enough. If you have a lateral approach, then you have a problem of subluxating the patella on the medial side. And these are the cases where you can do a rectus snip, probably is a better way. When you are doing the release, you must make sure that the popliteus is retained. And if it is very important, maybe that you just release the popliteofibular ligament. The lateral picrusting or just the pithing with a needle or a small blade, probably it is very important, and use the laminar spreader for this situation. Care is to be taken that lateral collateral ligament is not like a MCL, a large bend. It is better to be very careful while you are releasing. If you are doing an epicondylar osteotomy, then do not release and just do the epicondylar osteotomy. Because the first you release and then you decide to go for the epicondylar osteotomy is not a right way. Some of the simple cases, what you see, if you are seeing that correction is happening on the table under anesthesia, these patients, they need mostly no release. When you have a fixed valgus deformity like this, as we have seen under the navigation or robotic, it is probably easier to do use the unconstrained implant without having too much of the release of the soft tissues. That's what you see these patients, and that's what you see the patients follow up at a long follow-up of 5 years or plus. The patients who have a fixed valgus deformities, post-traumatic, having a lot of stiffness, probably these are the cases which are difficult. They need more release, they need more care, and that is what you can see that you can do it with the principles that we have been discussing today. If you follow all those principles, it is possible. Valgus deformity with a extension laxity are another difficult situation. There you have to follow the principles that you make the femoral cut, the distal femoral cut less, and follow the right principles, and then you can have a good result as what you see here, a long follow-up. When you have a subluxating joint, very stiff knee, probably it is very important to have a constrained implant ready with you in these cases, because these are the cases where you have to be pre-operatively prepared to have all kinds of hinge knee, these constrained implants, and the extension stems, etc. When you have extra-articular deformities, when you have a fixed valgus deformities, when you have a fixed valgus deformities, epicondylar osteotomy, as has been shown earlier, is a very easy way. And you have a large chunk of the epicondylar osteotomy, then fixing it up is very easy, and it gives a very reliable result in most of the cases. When you have a extra-articular deformities, what you see, the hypercorrected high tibial osteotomy, these are the cases where you can do the simple metaphyseal osteotomy, fix it with a small staple, and have a good correction in these cases in a very simple way. Just you have to protect the knee implant, knee for a short time. When you have a fixed valgus, long-standing subluxating patella, probably these are the difficult cases. You have to have a constrained implant where you're ready for all these cases, and also be ready for the epicondylar osteotomy, which is a far easier and better bailout option. In this case, what you see is you have a epicondylar osteotomy. You can release the lateral collateral ligaments, lateral structures, and fix it up where it is best suited in that particular case. And that's what you see this patient. They follow up, and you can see that this patient is having a reasonable correction. Leaving some amount of valgus in my practice has been a very easy way. The important pointers at the end of this webinar are: you must have a meticulous preoperative planning. Required constraint of the implants must be kept in readiness. Study on under and over-corrected genovalgum. Slight undercorrection will reduce the need of the release and provide better stability and function. And secondary stabilizers must be preserved. Where you do the epicondylar osteotomy, probably it is better to save the bone stock. You use the CR knees, because you will not have to remove the box. I think these pointers, if we follow, and the discussion that we have had, wonderful discussions, I'm sure that the valgus knee will be an easy case to deal with our all senior and junior colleagues. Thank you so much, Anil.
Thank you, Dr. Rajeev. Thanks a lot. I think it's time to now wind up the session. We are already, we overshot by 25 minutes.
Right.
So thanks to whole faculty who, despite their constraint, participated. Many of them were traveling, and we could have more discussion. But so for the benefit of time now, I think we now call it
yes.
a day.
Thank you so much, Anil. I think it's very well done. Very good discussion.
Yeah.
We could see Ajith also from the airport. Thank you very much, faculty.
Thank you.
Deba,
Thank you.
Dheeraj, Mrinal, Ajith, thank you so much, Anil, for a wonderfully convened webinar. Thanks so much. We'll close it now.
Thank you, Chandrasekhar.
Thank you, Chandrasekhar.
Good night, everybody.
Thank you. Good night.
Good night.
Making all the efforts. Thank you.
Thank you, Dr. Anil and Dr. Rajeev. Good night.
Good night.
Thank you, Dr. Anil and Dr.
Safe flight to
Rajeev.
those who are flying.
Yeah, have a safe journey.
Thank you. Thank you.